Next, let's talk a bit about jaundice. As you know from the physiology portion of this lecture, the liver is responsible for conjugating the unconjugated bilirubin, which makes it water-soluble. Unconjugated bilirubin is carried in the bloodstream attached to albumin. Conjugation allows for excretion in bile and then passage out of the body through either feces or urine. We're about to talk about various liver conditions, many of which have jaundice as a clinical feature. And understanding the basic physiology of bilirubin will help you differentiate the types of jaundice. Jaundice presents as a yellow coloring of the sclera, which you can see here, or yellow coloring of the skin. This happens when it has a concentration of greater than 2.5 mg per deciliter in the blood. We can think about jaundice in terms of unconjugated and conjugated bilirubin. Hepatocellular jaundice involves high levels of both conjugated and unconjugated bilirubin. The liver cells here are injured and they release their contents, and this is why you get a mixed form of both direct and indirect bilirubin. The conjugated bilirubin passes through the bloodstream into the urine, so the urine bilirubin is also high, and some passes out through the bile, giving normal urine urobilinogen, unless there is great damage, in which case this pathway is reduced. This is what you would see in hepatitis and cirrhosis. Obstructive jaundice, on the other hand, you can associate with the typical examples of gallstones or pancreatic cancer. Obstructive jaundice is a form of conjugated hyperbilirubinemia. The liver is conjugating always as it usually does, but the pathway out through the biliary system is blocked. The conjugated bilirubin is forced out of the hepatocytes and backed up into the bloodstream, and it passes hematogenously to the urine. The urine urobilinogen is reduced because there is no bile passing into the gut, and so the bacteria that convert the bilirubin to urobilinogen aren't able to do their job. Finally, hemolytic jaundice is primarily an unconjugated hyperbilirubinemia, which you can see here. In a patient with an otherwise healthy liver, conjugation does continue, but there is not enough conjugation to keep up with the high levels of unconjugated bilirubin that are present in the bloodstream following hemolysis. The unconjugated bilirubin is attached to albumin, so it does not pass into the urine, and the normal amount of conjugated bilirubin does pass through the biliary system into the gut, where it can be converted to urobilinogen and eventually reach the urine. Okay, let's go on to jaundice in neonates. This is a very large topic, most of which will not be tested until step 2. So here we will just mention the physiologic or normal form of neonatal jaundice. When neonates are born, the enzyme UDP glucuronal transferase has not yet fully matured. Because the neonates are lacking this essential enzyme, there is no way to conjugate bilirubin, and an unconjugated hyperbilirubinemia develops. The visible result of high bilirubin levels, as you know, is jaundice. The major concern when this occurs is preventing kernicterus, which is irreversible brain damage. Specifically, bilirubin passes through the immature blood-brain barrier and deposits in the basal ganglia and hippocampus. The treatment for hyperbilirubinemia is phototherapy, which must be performed in order to avoid kernicterus. The phototherapy converts unconjugated bilirubin to a water-soluble form so it can be excreted. Okay, now let's talk about a number of inherited forms of hyperbilirubinemia. It's easiest to think of this by the process of bilirubin uptake, conjugation, and transport. The first is Gilbert syndrome, which has no clinical consequences. As you can see in this diagram of a hepatocyte, Gilbert syndrome is caused by an error either in the uptake of bilirubin from the hepatic sinusoid into the hepatocyte itself, or a mildly decreased function of the UDP glucuronal transferase enzyme. In situations of fasting or stress, an unconjugated hyperbilirubinemia may develop without any overt hemolysis. Crigler Najjar type 1, like Gilbert, involve the same UDP glucuronal transferase enzyme, except in type 1 Crigler Najjar, the enzyme is completely absent. In this situation, bilirubin cannot be conjugated whatsoever, and this is fatal. The disease presents early in life, and jaundice and kernicterus develop. The type 2 form of the disease is less severe and can be treated with a phenobarbital, which increases liver enzyme synthesis. So we've discussed Gilbert, which can be a problem with uptake, and Crigler Najjar, which is an error in conjugation. Next, let's discuss Dubin-Johnson and Rotor syndrome. There are specific transporters that pump conjugated bilirubin from the hepatocyte into the bilirubin canaliculi, and when these are genetically altered, a conjugated hyperbilirubinemia develops. Dubin-Johnson is a congenital conjugated hyperbilirubinemia. It's relatively benign, with the interesting finding of a liver that is grossly black appearing. This is a key finding on the boards, and it should make you think of Dubin-Johnson. Rotor syndrome is even milder, but it does not have a black liver. Another important function of the liver is to excrete copper into the bile. Wilson disease is an autosomal recessive disorder where the excretion of copper is inadequate, and the copper is unable to enter the circulation bound to ceruloplasmin. Copper is normally excreted into the bile by the ATP7B gene. Where does copper accumulate if not excreted properly? Well, it accumulates in the liver, brain, cornea, kidneys, and joints. There are a variety of clinical manifestations due to the buildup of copper, and they're organized here by the simple mnemonic, copper is hella bad. C stands for the ceruloplasmin being low, cirrhosis, and corneal deposits. These are known as Kaiser-Fleischer rings, which you can see here as being a golden brown ring around the cornea. C can also stand for the increased risk of hepatocellular carcinoma. Hella bad also stands for hemolytic anemia, basal ganglia degeneration, asterixis, and dementia, dyskinesia, and dysarthrias. It's very important to recognize this disease early on before permanent brain damage is incurred, because it is quite treatable with penicillamine or trientine to remove the extra copper. Okay, let's do a flash quiz in order to solidify everything we've learned. What 5 organs accumulate copper in patients with Wilson disease? That's right. As we just went over, it's the liver, brain, cornea, kidneys, and joints. We just noted the harms of high copper levels, and now we'll consider the harms of high iron levels. Hemosiderosis is the term for deposition of hemosiderin, and hemochromatosis is the disease caused by the deposition. The classic triad includes micronodular cirrhosis, diabetes mellitus, and skin pigmentation, the so-called bronze diabetes. This is a critical association that you will find helpful on the boards. The cirrhosis gives an increased risk of hepatocellular carcinoma, as well as congestive heart failure. A mnemonic that may help you with this is hemochromatosis can cause deposits. H stands for the hepatocellular carcinoma risk, C for cirrhosis and congestive heart failure, and D for diabetes mellitus. Hemochromatosis may be primary, which is through autosomal recessive inheritance of a C282Y or H63D mutation of the HFE gene, or it can be a consequence of chronic transfusion therapy, as in patients with beta thalassemia major. You will need to know these mutations for the test. Of course, the iron level is high and the ferritin is high as well. But the TIBC is low because the body does not want to encourage any more iron storage in its already overloaded state. In fact, the iron level can be so high, up to 50 grams, as to set off metal detectors. Women have slower progression than men due to their menstrual cycles. The treatment is removal of iron with repeated phlebotomy, although drugs such as deferoxamine or defersirox, which are iron chelators, can be used if the patient has anemia. There is an association of this disease with the HLA-A3 antigen. Okay, now we'll talk about some diseases of the biliary tract. All of these present in the same way, with pruritus, jaundice, dark urine, light stools, and hepatosplenomegaly. The labs are also the same since they are all obstructive, with an increase in conjugated bilirubin, high cholesterol, and high ALP. However, the causes are quite different. Secondary biliary cirrhosis is a term that encompasses a number of conditions that end up impacting the biliary system, such as gallstones, strictures, chronic pancreatitis, and pancreatic cancer. These conditions can put pressure on the intrahepatic ducts by their external compressions, and this leads to injury and fibrosis, as well as bile stasis. These diseases can also be complicated by ascending cholangitis, where organisms from the gut travel in a retrograde manner up the bile duct to cause a life-threatening infection. Primary biliary cirrhosis, on the other hand, is an autoimmune disease. There is no preceding trigger that launches that disease that is known. Histologically, you can see lymphocytic infiltration as well as formation of granulomas, which you can see here on this histo slide. The test of choice for PBC is the anti-mitochondrial antibody. Because there is an autoimmune etiology, the disease can occur with other autoimmune conditions, such as CREST, rheumatoid arthritis, or celiac disease. Lastly is primary sclerosing cholangitis, the etiology of which is unknown. Histology will show an onion skin fibrosis in the bile duct, and ERCP demonstrates alternating strictures and dilation that can cause a beating pattern along the bile ducts, which you can see here. Hypergamma-globulinemia is present, and there is an association with ulcerative colitis. In fact, it's fairly unlikely that you would see a question about this disease outside the context of ulcerative colitis. So this is really important to know. Even though most people with UC are female, those that are most prone to primary sclerosing cholangitis are males with ulcerative colitis. Primary sclerosing cholangitis can lead to secondary biliary cirrhosis, or cholangiocarcinoma. Okay, now let's talk about gallstones. There are different causes and different types of stones. Some are caused by increased cholesterol, increased bilirubin, decreased bile salts, and simply gallbladder stasis can all cause gallbladder stones. The two types are cholesterol and pigment. Cholesterol stones are much more common, about 80% of all stones. They are generally radiolucent, although 10 to 20% are opaque due to calcifications. Risk factors for developing cholesterol gallstones include obesity, Crohn's disease, cystic fibrosis, use of clofibrate or estrogens, multiparity, rapid weight loss, and also Native American heritage. These are summarized by the mnemonic of the 4 F's: female, fat, fertile, and 40. Pigment stones are less common, and they're radiopaque. These are found in patients with chronic hemolysis, alcoholic cirrhosis, and biliary infection. Advanced age is also a risk factor for both types of stones. The diagnosis of each is generally by ultrasound, but you can also use radionuclide scans, and treatment is with cholecystectomy. Gallstones most often cause cholecystitis, but they can also cause ascending cholangitis, acute pancreatitis, and simply bile stasis. Ascending cholangitis can be life-threatening, and it is marked by Charcot's triad: jaundice, fever, and right upper quadrant pain. Additionally, many patients experience the pain of biliary colic, though some diabetics may not feel this sensation. One relevant physical exam finding is the Murphy sign, which is considered positive if there is cessation of inspiration with right upper quadrant palpation due to intense pain. Rarely, gallstones can cause a fistula between the gallbladder and small intestine, which allows air to enter the biliary tree. In the event of a fistula, a gallstone could go directly into the small intestine without passing through the bile duct system and obstruct the ileocecal valve, causing ileus. This is called gallstone ileus. This will sometimes show up on the exam as an image with air in the biliary tree. Here you can see a diagnosis done by ultrasound. Just in case you didn't get everything about cholecystitis you needed, here's another brief review. The definition is simply inflammation of the gallbladder. Most commonly, it is from gallstones, but rarely it is due to ischemia or infection such as CMV. If the bile duct becomes involved, lab tests may show an elevated ALP. Let's do a quick flash quiz in order to make sure we got all of that. Gallstones can cause what 4 major complications? The 4 important ones to know are ascending cholangitis, acute pancreatitis, bile stasis, and cholecystitis.